right. Well, I'm really pleased to be back here. I was here a couple of years ago when I finished the certificate course in practice-based research network methods. And so it's a great honor to have the invitation to come back and talk about some of our work. And I'll be covering several different issues. The learning objectives are to talk about screening in health inequities, how engaging with community members can help, and then also thinking a little bit more upstream about the social determinants of health. And I'll try to respond to this really great theme for the conference today and keep things broad. My understanding of a plenary session is that there's not much else going on at the conference, so you don't have much choice but to be here in this room while I'm talking. So I'll try to cover a number of different topics that might keep you interested. This is the Scarborough Bluffs. You may not think of cliffs and beaches when you think of Toronto, Canada, but this is in fact not far from the city centre. Next time you're in Toronto, if you're there for the NAPCREG meeting in the fall, I'd recommend that you check out the Bluffs. But if you go, I have a piece of advice, and I can say this only because I'm a doctor. You should try and avoid falling off the cliff. Because bad things happen when you fall off a cliff. Our approach, I think, in healthcare, in terms of services and research, is mostly to focus on the ambulances at the bottom of the cliff. So when someone falls off, someone has a heart attack or stroke, or a complication of HIV/AIDS, we try and build ambulances that are better or provide more ambulances at the bottom of the cliff. And there are other approaches that I'm going to talk about today. You know, you can build a fence to try and prevent people from falling off. You can put a net so if people do fall off, you prevent most of the harms. Or if you think ahead, you can try and move people further away from the edge of the cliff. And this is not my idea. This analogy is from Dr. Kamara Phyllis-Jones and her colleagues. And I think what this slide demonstrates is that if you have a really good, powerful idea, you can get away with really bad drawings. And so the idea and the drawings are both from Dr. Jones and her colleagues. And I'll be returning to this diagram several times to place the different topics that I'll cover. It's known in many countries that if you have a lower income, if you have less wealth, that you die sooner. It's true in the United Kingdom, it's true in India, it's true in Brazil. It's true in the United States, where the life expectancy gap between the different income quintiles is about 10 years. It's also true in Canada, where the gap is the same. It's 10 years. Despite a number of differences between the countries, poor people die sooner and have poor health while they're alive, both in Canada, the United States, and virtually every country. There are multiple reasons for this. I'm first going to talk about medication access. So we know that there are life-saving treatments. There's a cocktail of medications that you can take after you have a heart attack that will decrease by 50% the risk of having a subsequent heart attack and reduces the risk of death. We know that antiretroviral treatments have taken HIV/AIDS and converted it from a condition that was almost uniformly fatal to one where people can live to their 60s, 70s, 80s, and we hope beyond. Overall an increase in life expectancy of more than 40 years. But yet there are people who don't have access even to these life-saving treatments. And the two countries that stand out as the worst in the world for high-income countries when it comes to medication access are Canada and the United States. For most high-income countries, the rate of cost-related non-adherence, so that's the rate of people, the percentage of people in the population who report not taking a medication as directed in the last 12 months, specifically because of the cost, it's more than 10%. It's around 10% in Canada and the United States. In most high-income countries, it's around 5%. And you might be wondering how that might be the case in Canada, where we have a publicly funded healthcare system. And many of you might be thinking there must be some kind of program, some government program for low-income people who don't have access to medications, who can't afford antihypertensive treatments, treatments for diabetes, treatments for HIV/AIDS. And the answer is there is not. In Canada, healthcare services are publicly funded. So there's universal access to healthcare services, seeing a doctor, attending the emergency room, having your appendix out, having your heart stented. Those are all services that are publicly funded. And the vast majority of people living in Canada have access to those services without any charge. But medications have not been included in the publicly funded healthcare system. So there are a number of, there's a patchwork of programs that are supposed to provide people with access. Around 60% of people in Canada have access to a private insurance program that includes medications and some other so-called ancillary medical services like dental care and physiotherapy. And around 20% of the population in Canada would have access to a publicly funded insurance program like that. So those would be people on welfare, social assistance, disability. But that leaves a substantial number of people who don't have any insurance. And in addition, people with either private or public insurance also sometimes have co-payments or deductibles that make the plan out of reach for them, even though they are indirectly paying into the plan. So I'm going to tell you a little bit about some of the work that we're doing. And when we're talking about medication access, we're talking about, we're still talking about the ambulances to some extent. So we're talking about treating complications, you know, like after someone has a heart attack, what can we do to prevent the next one? And in some cases, we're talking about the nets. So, you know, after someone is diagnosed with diabetes and they've suffered some of the harms, what can we do to keep them healthy and prevent subsequent or catastrophic harms like heart attacks, strokes, death? So what we decided to do, you know, because of some of the people affected, and so, you know, the low-income people who typically don't have private insurance, these would be taxi drivers, food service workers, factory workers, artists, entrepreneurs. So these people generally wouldn't have any private insurance, and in many cases don't have an income that would be sufficient to pay for medications, even moderately priced medications. And so we wanted to do a study in a practice-based research network that would be responsive to the concerns and the needs of these people. So we decided to engage with the community, and we unsuccessfully tried to reach people through a variety of means. We had a summer student. Literally, we purchased 1,000 phone numbers for people living in the area around the hospital, and we had an intrepid summer student call them and get hung up on about 980 times, and recruit virtually no one through cold calling. We sent letters. So eventually what we decided to do was make t-shirts that said free medicines, and we walked around the area around the hospital. And we had a little postcard that we gave out and said, we are interested in doing some research in this area. Do you want to join us and help direct it? And this raised a lot of eyebrows. The Research Ethics Board, Institutional Review Board, was wondering like where we might have got this bad idea. And there were also questions like, do you really think these people are going to want to participate, and do you think that they're going to have good ideas? And we were very successful in recruiting people. So we were able to, we were targeting 12 people, and we ended up reaching more than 20 people who are interested in attending monthly meetings with us to help design this research project. The only problem we ran into, and this was before marijuana was legalized in Canada, we went down a street with a number of shelters where there's a high turnover of illicit drugs, lots of drug dealers on the street, and a few of them thought that we were maybe competition who were going to be undercutting, and so when we said free medicines on our t-shirts, they had a lot of questions about whether or not marijuana was one of them. The answer is no. So And I'm really pleased now, on the next slide will be the results of our clinical trial that I'll be presenting for the first time here today. So we designed this intervention with the community members who've now met 28 times with us, starting around 9 months before we did the trial, where people are recruited from primary care sites, 6 sites in Toronto as part of the Utopian Practice-Based Research Network that Michelle Griever leads, and also 3 sites in rural Ontario near a place called Manitoulin Island, for those of you who are familiar with it. For those of you who are not, you should, in addition to the Scarborough Bluffs, try and get up to Manitoulin Island if you're in Toronto for NAPCRG in the fall. So we recruited these people who report cost-related non-adherence. So each of them said they didn't take a medication as directed. Either they didn't take it at all, or they didn't, they spaced it out, took it every other day, specifically because of the cost. And half of them we randomized to receive free access to medicine. So a pharmacist would mail the medicines to an address of their choosing, either their home, the clinic, or a shelter. And this was a carefully selected set of essential medicines based on the World Health Organization's list of essential medicines that they say should be accessible to people all over the world, and yet there are people in Canada who don't have access to them. And then there was a control group who had their usual access to medications, which in most cases meant poor access. And both groups had the same access to care, so they were attending primary care visits as usual, and there were no instructions about changing care. And what we found is there was about a 10% absolute increase in the fraction of patients who reported and were measured to be taking their medications more than 80% of the time, which is the generally accepted definition of adherence. So it wasn't we didn't knock it out of the park in terms of adherence. So the adherence went from, the fraction went from the control group of around 35% to, over 45% in the intervention group, which sounds pretty low. So, we're giving people free and relatively convenient access to medicines, and still only 45% of them are taking every single medicine as they should. And just one thing to note, if you're not familiar with the literature, is that adherence is high when you don't measure it. If you're just a doctor prescribing or a nurse practitioner prescribing people medications, you obviously need to assume that people are taking the medication. Otherwise, why do you get out of bed in the morning? What's the point? But in any study where you rigorously measure whether or not people are taking the medications, adherence is usually around 50%. And in our lower income population of study, it was even lower. And it's, if you look at other interventions aimed at improving adherence, they can be on the scale of, an absolute increase of 3 or 5%. So relatively speaking, although it's not a huge increase, it was an increase. And there was a trend towards improvements in the hemoglobin A1C of a magnitude that would be similar in general to adding an additional agent. So this was, not adding an agent, just providing people with the medications they were prescribed before in a way that would increase the likelihood that they'd take them. And blood pressure was substantially improved in the intervention group. There's no improvement in cholesterol. We had a small number of people in both groups who were taking treatments for HIV/AIDS, so the number was so small that we've suppressed the findings. But what I could say is, disturbingly, it does seem like there are people in the control group who weren't taking their antiretrovirals. We know what the consequences would be. The biggest improvement that we saw was in an outcome that before we engaged with the community, we didn't think to ask about. And it was not a question specifically about medications or the cost of medications, but about whether or not people could make ends meet, whether people could pay the bills, pay their rent, afford food. And in the control group, it was around 25%. And in the intervention group, it was 75%, over 75%, so they could make ends meet, meaning that access to medications or the cost of medications could be the difference between someone being able to pay the rent, afford food, not go into debt. And partly through the direction of the community guidance panel, we've been following the experiences in order to flesh out the results of the study. So there's some short documentary-style films being made about 4 people, 2 in the control group who've continued to have poor access to medications, and then 2 in the intervention group who have seen their access improve. And it's been interesting also to track some of the differences between the people in the urban site and the rural sites. And I grew up in Toronto and have never lived in a rural community. But learning about what poverty looks like in a rural community, some of the stories are about people who don't really have any expenses, because they grow their own food and are self-sufficient in many ways, except when they get sick, and then they have this large expense which was not anticipated, and there are people in the videos who talk about what that means. And we've also done some qualitative work to flesh out this finding about making ends meet. And so this is a concept map where you take responses to an open-ended question and sort of map them after you have some people sort through them. And some of the interesting things that we found through doing this, through this sort of analysis, is the improvements in the doctor-patient relationship, which we didn't necessarily anticipate, since there wasn't anything about that interaction that was directly changed by the intervention. People were still going to their doctor, having medications prescribed in the same way, but multiple patients reported that their doctor-patient relationship was better, partly because I think there was this there was a tension when a doctor would prescribe a medication that the patient couldn't afford. The patient would come back not having taken the medication, usually not reporting that, and that was gone. And people reported attending their appointments more so than they did before. And some of the reasons there was that people were saying that they thought it was pointless to go back and get prescribed a medication that they couldn't afford. And then there were multiple comments about sacrificing other essential things, mostly food. So people talking about how it had implications not just for them, the intervention, but mostly for their families. We did an economic analysis of this short list. It's only 136 medicines that we've included in the list, and that covers treatments for depression, schizophrenia, high blood pressure, diabetes, HIV, hepatitis. So we wanted to know how much would it cost, or what would the economic implications, just thinking about direct drug costs, be if these medications were publicly funded across Canada. And it would involve an additional public expenditure of about $1.2 billion across Canada. But it would be offset by decrease in private spending, including out-of-pocket expenses and insurance premiums of around $4 billion for an overall saving of around $3 billion. And some of these findings, or actually all of the findings, have been submitted to this National Advisory Council on the implementation of pharmacare that Michelle Griever mentioned in the introduction. And one of the recommendations of that advisory council to the government was that a list of medicines, such as the one we used in our study, be a starting point for a new public policy in Canada that would have medications fall under the publicly funded single-payer system that we have now. And I assume, since we hear a lot about American politics, that you all know about Canadian politics. That's how it works, right? That you follow it very closely. So you would know that there's an election coming up in the fall in Canada. So while it's very encouraging, and I've obviously never expected that, anyone would read about the sort of research that we're doing, certainly not that the government would take an interest and include it in a recommendation. And so, yeah, that's all very heartening. There is an election in the way of this becoming a reality. So I can, I guess if you're at NAPCRG in the fall, we'll see the outcome of that then. All right, let's switch gears now. So the second part of the talk will be about screening, and most of the screening interventions that I'm going to talk about, they're either a fence approach where you're trying to prevent something bad from happening to people, prevent people from falling off the cliff, or a net where you're trying to catch something early before most of the harms have accrued. This is just a full body MRI, which I think I just include this slide because when I mention sort of screening and preventative health, I think this is sometimes what what patients might have in mind, and I'm not sure for the clinicians in the room if you ever had a question about like whether a full body MRI would be a good idea. I have, so there's a general view that more screening is better, having more information, a more fulsome, rigorous look at the body is a good idea. And, but there are some principles about when screening at the population level makes sense and when it doesn't. So there are 10 principles that were, that have been around from the WHO for around 50 years. And just paraphrasing them, there should be an important issue, an important problem that we can address. There should be some kind of latency period where people are generally not symptomatic or only have mild symptoms, because otherwise you shouldn't need screening to pick up the problem. There should be a good test, a fairly accurate test that's acceptable to people. Otherwise, screening is not going to work, and there isn't much point in doing these tests if there isn't a treatment that's effective and acceptable. So that's another criteria. And then if you're going to implement a screening program that's going to be general to the population, such a program has to be feasible. So there are some examples that are fairly clear. Where screening helps. So colorectal cancer is one, and you can think about how the principles apply there. There could be a precancerous lesion that's asymptomatic, it's not causing anybody any problems. But if you don't identify that, then it becomes a cancer. It can cause serious problems, can be fatal. Alternatively, if you have a screening program for colorectal cancer, you identify early lesions, intervene, remove them. You could save lives, and there are trials of screening for colorectal cancer that show that it does help. Hypertension, diabetes, similar examples where you can identify things early before the most important harms are present, and you can effectively prevent them. So I just want to extend, and in responding to the theme of the conference, talk a little bit about some other examples and how thinking about these principles in combination with thinking about health equity might help. I talked before about the relationship between income or wealth and health. That relationship is not it's not neutral. There are people who are discriminated against because of race, ethnicity, gender, and those people are known through multiple studies. Even when you correct for wealth, even when you correct for income and other factors, have worse health outcomes. They have worse other outcomes. They also have worse income, etc. And in the cliff analogy, what is happening here is that there are some people who are being pushed closer to the edge of the cliff, and some people who have much more room to move around. And in terms of screening, when you look at who's getting screened and who is not, it is people who are facing discrimination in other spheres, when it comes to hiring, when it comes to educational attainment, who, it turns out, also are getting underscreened, even when you correct for factors such as income and wealth. And when I talk about this with some of my clinical colleagues, they say, well, yeah, I mean, some people don't come in. Or when they come in, they have multiple issues and it's difficult, and screening is not going to be a priority for those patients. I think one of the studies done by Dr. Aisha Lofters, one of my colleagues, and others, that shows that is probably not the primary reason. People not coming in is a study done in incarcerated women in Ontario, where they, as their population, took women who were 3 years overdue for their cervical cancer screening, and in some cases for other screening maneuvers too, such as mammograms and colorectal cancer screening. So they were 3 years overdue when they were incarcerated. And then they followed women who were incarcerated for 3 years after that, versus a control population of women who were not incarcerated. And they found that the incarcerated women were less likely to get the screening that they were overdue for at the time that they were incarcerated. So they were, and I don't mean to make a joke of this, but they were a captive audience. They were incarcerated, so they weren't necessarily, avoiding interacting with institutions. So there could have been, I think we could imagine, a program that would have helped to address the inequities, and that didn't happen in Ontario. So I think, I mentioned this example and spent some time on it to make the point that if we prioritize screening for these populations, we could probably do it. And I think that's where the issue lies, is that we just haven't made the decision to do that, to focus on equity. And on the other hand, there are, I think, and this may be slightly controversial, some screening maneuvers that are questionable, but that happen. Screening for dementia, depression, prostate cancer. To some extent, all of these screening maneuvers fail to comply with the principles of good screening. For dementia, no good test or treatment. For depression, it's symptomatic at its onset, and so generally you are able, without screening, to identify people who are depressed, and you can offer treatments. Prostate cancer, there's not a good treatment, and there's some controversy about, it's not a good test, and there's some controversy about who's going to benefit from treatment. So I mentioned these things. There are other examples of questionable screening interventions. Just to point out that we have a limited number of resources, and you could think about creating a system to screen people for depression, or we could put our limited resources into taking screening maneuvers that we know work and ensuring that everyone has access to them, including people who are discriminated against in most spheres of their life. You'll also notice, and this is not the point of my slide, that there are some slight differences in the recommendations of the U.S. Preventative Services Task Force and the Canadian Task Force on Preventative Health Care here. But these are all examples where there's not a strong recommendation in favor of screening versus colorectal cancer screening, hypertension, diabetes, where I think there's wide agreement that screening helps. And I think we're going to hear more in the second plenary today from Dr. Epling about the work of the U.S. task force. I just want to mention briefly here that this is not meant to create any sort of tension between the Canada and the United States. It's not like there's a rivalry or anything. I think you have all. I think you all have heard of the sport called basketball, although it was invented by a Canadian, James Naismith, and the championship currently resides in Canada. I had heard that you also play the sport here. So for screening, before I leave it, my thoughts here are that we should both focus on effective screening programs and ensure that access to screening is equitable. Otherwise, we compound the inequities. So Otherwise, what happens is the people who are being pushed up against the edge of the cliff because of inequities in society and discrimination, then additionally have a poor quality fence or net. And so we can compound the effects. Now, in the last part of my talk, I'd like to talk a little bit about some of the upstream factors that determine health. And using the analogy, this would be potentially the most fruitful way to promote health, to try and move people further away from the edge of the cliff. So one of the things that I found really surprising when I started learning about this area was that although it's very well known that there is this gap in life expectancy between the rich and the poor, the reasons for it are actually not very clear. Some of the explanation would be related to personal behaviors, such as tobacco use. So tobacco use in most countries is more common among low-income people than high-income people today. That wasn't always the case. But that only accounts for around 15 to 20% of the life expectancy gap. So a substantial amount, because smoking is so harmful and because there is a disparity. The homicide rate is different across income groups, so that explains a little bit of the gap. But of the known factors, they would explain less than half of the life expectancy gap between the rich and the poor. And so people have looked for other factors, and one of them that, somewhat to my surprise, has received a lot of attention is stress. The impact of stress, of knowing that you have a lower income than other people, of having, a stressful job, the effect that could have on health and life expectancy. And I'm sure that does stress does have a detrimental effect on people's health. But thinking about my own patients, I think one simple place to start might be access to tangible things that we know are important for health. And this project that I'm just going to briefly describe grew out of some of the comments that participants in our medication trial made, particularly about food. So there was one participant I remember who had called me about something else, about actually a little an adverse event that had happened. And said, I'm really grateful for the medications. It's good that I don't have to worry about that, because I've been, my doctor was kind of on my case about not taking my diabetes medications. But he said, you know what, now the dietitian is really on my case. And I just know that I'm not eating the right foods, and that is on my mind. And so he was asking me, are you doing something on food? And the answer is that we weren't. So I decided to look into it. And so there are some examples that I had known of before of tangible things that can promote health. So this is a baby box that's used in Finland. So it's a cardboard box that all new parents get. So not low-income families. This is everyone in Finland who has a child gets this box. So people every year they announce, what are the colors going to be, what are the patterns going to be, and it's a big cultural thing now. So there are a number of ways that this can promote health. One of them is the box. So the babies actually sleep in the box as newborns, and so there are some observational studies that indicate that the distribution of these boxes has reduced the rate of sudden infant death syndrome, probably because babies are sleeping on their backs in these boxes. My wife works for the UN Refugee Agency, and they do things. They give water tablets out and water purification systems out to families who have had to flee their homes. These haven't really been studied, but I think most people would accept that there would be health benefits. There are other programs that, historically have served a variety of purposes, including providing people with things that they need and making a point about why certain people are being discriminated against. This is an example from many years ago, the Black Panthers. So we did a systematic review. We were trying to find studies of all types where people were given something, a tangible thing, and a health outcome was measured, and where the study design was such that even if there was some other service that was rendered, that most of the effect we think is from the free good that was distributed. And I got a lot of pushback here when I talk about distributing things for free. And the definition of free that we used is that you didn't have to pay for it. And especially when I talk about medications and free medicines distribution, people say, well, they're not free because somebody had to pay for them. But the ordinary definition of the word free means that you don't have to pay for it at the point that you use it. Walking down the street, for example, is free, even though it costs a lot of money for you to walk down the street, right? Somebody had to build a sidewalk, there have to be lights, they have to be policed, there are crossing guards. So you could imagine a system where at the end of your sidewalk, at the end of your walk up, leading to the sidewalk, there was a turnstile there, and you had to put in like $1 before you wanted to walk down the street. In that case, walking down the street would not be free, but in the case that we have today, I think in most places, walking down the street is free. So when we talk about free distribution, we mean you don't have to pay for it. Obviously, it does cost money, and somebody had to pay for it at some point. So we searched the literature, and we got from 3,000 records down to just around 55 studies that were described in under 60 articles, and they were from all over the world on all sorts of different interventions related to, there were food programs for children, there were the housing first interventions, where, the thinking there is for people who are underhoused, mostly people with serious mental health problems, rather than trying to provide them with services to get them able to participate in programs first and then provide them housing, just provide them housing first. And then, other supports in the hope that they will be better able to take advantage of services after they have a stable address. So there were a number of studies related to that. Mosquito nets, hand washing interventions, there were hip protectors to prevent hip fractures, bicycle helmets. So we put together all of these studies, and we found that the two interventions that were studied the most were housing and food. And I'll just briefly give you some of the results. So most of the food studies measured either deficiencies or the risk of obesity. And there were different effects, but most of the effects were neutral. So the food programs did not either improve or harm health. But of those that had a substantial effect, a statistically significant effect, most were positive. And the case was the same for housing, and virtually all of these studies would have been of the housing first variety. And so what we took from that was that in general, providing free goods can improve health, but that it often doesn't, and that there are some risks. So what we're doing now, and what we're engaging now with communities around is designing a different intervention. So not just providing people with medications, which is as I was saying, like in the cliff analogy, it's fairly low down, like more thinking about ambulances. But now we're more thinking about how to move people away from the edge of the cliff with goods. So we're designing a basket that mostly includes food, and also some personal hygiene items, which are another item that seems to be associated with some health gains. And we're trying to design it in a way where there's some core elements that everyone will get and some parts that will be optional, and coupling it with some suggestions about how to prepare some of the foods. And then our plan is to measure the impact on health. And we have also understood the importance of this general question about whether or not people can make their ends meet. So I'll just wrap up by telling you a little bit about a program that we started partly because as we've been talking more about these issues around the social determinants of health and addressing health inequities with clinical colleagues in the Practice-Based Research Network, a lot of them have said, yeah, I mean, that makes sense to me. If people had good food, their health would be better. If people had stable, healthy housing, their health would be better. And, there are studies showing that asthma control is better if you don't live in a moldy apartment. But clinicians said, but what am I supposed to do when someone comes in and they can't afford food, or they're behind on their rent and they're going to get evicted from this place, which is not even very healthy. In my 15 minutes with patients, what am I supposed to do? So one of the things that we are doing now is we have an on-site lawyer providing legal services to people, and we're evaluating the effect of that. And this is not our idea. Actually, I've been to meetings in Washington about what you call medico-legal partnerships here, where legal providers and health providers work together to help people, mostly disadvantaged people. And there have been, as described in the literature already, multiple gains. So I can think of examples where I had written multiple letters to a landlord about an accommodation that one of my patients needed, and those were usually denied, or more commonly, they'd say, yes, we're going to do that, but there's a 5 or 7 year wait for this person to be moved to a different accommodation. And then what happens now is that, we refer to the lawyer, and then the lawyer calls the landlord, says, I'm the lawyer working for St. Michael's Hospital. I think this patient's rights are being violated. And then, what do you know? But next month, there's an opening, and the person gets moved. And now, so that's great for that person, and it's great if you have a lawyer on your side. But, that is not necessarily a solution for everyone, and the scalability of this intervention is maybe in question. So we designed this program so that a third of the time that this lawyer has on site, and the lawyer's full time with us, is spent on law reform and policy change. And we've already had some small successes. One of them was for people, for refugees who are going to be granted citizenship. They still have to go through an interview, and for some of the people, depending on their circumstances, what they've been through before coming to Canada, they were persecuted or imprisoned by another government. For them, attending an interview with a government official it activates a lot of trauma. And so what used to happen is these people would have to go through an interview and fail it in order to be accommodated, and they'd have to pass the exam through some other mechanism. And there have been a number of cases where this has been quite harmful to some of our patients. So our lawyer was successful in advocating for this to change. So these people can be exempted from an in-person interview if there's evidence that it would be traumatizing. But although the program is working well, one of the problems with it is that, and although we had planned to educate clinicians about the potential benefits of this program, it's currently the case where around 80% of the referrals come from 1/3 of the clinicians in our network of clinics, and so we have realized that we haven't yet changed from clinicians viewing housing or discrimination as something that they cannot deal with, it's not their business, to something that they absolutely can intervene on. So we've been thinking a little bit, and we do this, we have a health equity survey where we try to get information about characteristics of people. So we try to track what's the gender, what's the race or ethnicity, what's the income level of the people that we're serving. And there's this idea that if we can identify trends, then we can design programs around it to address the inequities. But we haven't actually done that. And we've been thinking about whether or not it would be more useful just to ask about interventions instead. So instead of just asking about gender or race, we could ask people whether or not they've been discriminated against based on their gender, their race, or their sexual orientation. And that's something that now, with the lawyer, we can hopefully intervene on. And also, hopefully, if we accumulate a number of such cases, we can do things to help, change the law, change policy. And, additionally, and maybe this would be a little bit controversial, if we think back about screening, some of the potentially lower value screening interventions, rather than adding them on, or in addition to adding them on, maybe we should think about identifying people who would benefit from other interventions. And then if we do, maybe we can help put stories together and do research that's going to help improve public policy to address the inequities. So hopefully I've responded at least to some extent to the theme of the conference today. And, some of the, if I had to summarize in 3 points here, how I would respond to this question, one would be to focus on things that we know are likely to have a large benefit, and try to ensure that those interventions are accessible to everyone. And then maybe we should move away from trying to identify characteristics and doing research on them to just trying to identify people who will benefit from specific interventions and then offer them. And, I think those things are fairly feasible to do, and you could think about how research in practice-based research networks and otherwise could help. The more difficult challenge, I think, is just to keep equity on the radar, because I think a lot of resources go into just setting up programs that work and evaluating programs without necessarily considering who's getting left out or discriminated against. I'd be happy to discuss. Thank you very much for listening.
That was really inspiring and kind of far-reaching in so many of your lessons learned and studies to date. One of the things that really got my attention early on was when you sort of had the T-shirts emblazoned with free medicines, and you recruited what sounds like an amazingly engaged community and patient advisory group or panel and had all those meetings. And I was just wondering, as you kind of progress through your series of studies, if you could share with us some of your other strategies that have worked to maintain the continuous engagement and participation of patients and other community stakeholders. It seems especially important as the kind of trajectory of research that you presented as it goes forward to always be having that be so foundational. So thanks.
Great. I think the most important thing that I learned through this community engagement process, which was new to me when we started, is the importance of reporting back. So we typically would have the community guidance panel meet every month or every 2 months. And, I guess in the beginning, I maybe viewed them as, like you have a certain number of things you're working on for that month, then you get their input, and then you take it forward and you keep going. And I was just, I think at our second or third meeting, I was just held to account forcefully by one of the members who said, I mentioned this at, it was about how the pharmacist should contact the patients by phone. She said, I mentioned this at the last meeting, and you didn't tell me what you did with it. So we have put on the agenda now, after the welcome and introductions, the first item is reporting back on everything that we discussed last time. And I think that, and what we have been told by the community guidance panel members, is that's the most rewarding part for them, is knowing that what they did made a difference and we acted on it. And it has made them, these people, they're getting compensated very little, a very small amount of, we give them like a supermarket voucher and subway tokens for attending. So it's definitely not in any way what would we'd consider adequate compensation for attending these meetings monthly over many years. And that's what they tell us is most important, knowing that it made a difference and seeing the changes that we actually make to the study. The other part, and others who organize these meetings would know, the other part was the food. We also had to get the food right. So people come to a hospital with certain expectations about what's going to come to a meeting at a hospital with certain expectations about what's going to happen, and then at the first meeting we served pasta, lots of pop, with brownies for dessert, and people said, what's going on here, and they were absolutely right, and so we changed that part too, and actually. Now we're doing a project that's related to providing people with food.
Thank you for your comments and motivating us all to really start where we need to be. I think that we are all here in primary care recognizing the importance of prevention. I think you've been very strategic in the way you've approached it, and it's exciting and motivating. My question is, how do we get our subspecialty colleagues to partner with us in doing this work? Because we in primary care understand prevention, yet our cardiology colleagues, our nephrology colleagues, our colleagues in all these other disciplines who have a lot more money for their research programs than have been devoted to primary care. And maybe it's easier in Canada than it is in the United States, but just the funding sources for these types of programs are much more limited in most of the academic health centers. I'm curious to know how you have embraced those who are not prevention oriented to help you, and how did you fund this free medicine?
Great, really great points, and completely agree. This is, like most things, is a challenge in Canada, as it is, I think, I'm hearing in the United States. I guess our approach was to humbly approach the specialist, and the message being, we are primary care providers, not experts in diabetes management or COPD management, and we would like your input. So on the medications trial, we went through a long process of creating our list of essential medicines that involve peer review and from specialists in different fields. And so I think that was one of the ways to get buy-in, was to say, we need your advice. And even though, and not to be repeated outside of this room, just among friends, we actually didn't make many changes to the list. There actually aren't any secrets that diabetes specialists have about which medicines work and which don't. Actually, you could just look at the literature. So it may not have been 100% true that we absolutely needed their input, but it was very helpful. And obviously, I think part of the reason now if there's talk about having this list be part of a national policy, obviously there would have to be buy-in from all providers. And if there were specialists out there saying, this is a terrible list, this is made by family doctors who don't know what they're talking about, we wouldn't be getting very far. In terms of funding, I was told by multiple people, including some of my mentors who are specialists, that it's a bad idea to start your career on a project that's going to fail, because you'll never get anyone to fund a trial of providing people with free medicines. And the way that it actually worked out is we got a little bit of money to do the community engagement work that started before the trial. And then we designed this intervention that we then got a little bit more money to pilot from the foundation of the hospital and from a local government. And then we had those results that we were able to show to the provincial and national government, federal government. So the study is now funded by the Canadian Institutes of Health Research and the Ontario SPORE support unit, so the provincial government.
Very helpful. Thank you. Thanks so much.
Thank you.
I was just wondering, it seemed like you had a really diverse group of patients that are part of this research network and participated in your studies, ranging from frontier communities to urban communities. And and whether you did any cultural tailoring of either the free medications intervention or the free goods intervention, or whether you have a sense from the qualitative work whether it worked better or in different ways for different groups of patients.
Great questions. The intervention, it is really, we only have about 800 participants in this study. So we created one pharmacy that provides the intervention to all of the participants. The only difference is for medications that people need to start right away, those are dispensed by the clinicians at the site before the patient leaves. So it was more about trying to design an intervention and select an individual, the pharmacist, who was going to be sensitive to different needs. And that was one thing actually that we started doing with advice from the community guidance panel is members of the community guidance panel sat on hiring committees with us. So they, I think, took an equity lens to who should be hired. And they told us that in the postings for all of these positions, we should describe the sorts of populations people will be dealing with and put that as one of the criteria. And that's something that we did. So I think that was the most important way that we addressed that.
Thank you for the enlightening talk. I have a small question. You used two concepts. One is low income. The other one is poor access. I just wonder, how did you determine at what level of low income that translates or equates to poor access?
Yes, great question. For the medication trial, there was a lot of debate about how to reach the population that we were interested, people not taking medications because of the cost. One way would have been to look at whether or not people had insurance. Another way would have been to set an income threshold, which is maybe what's most commonly done. And what we decided to do was different. We just asked people when they were visiting their primary care providers whether or not they had failed to take a medication as prescribed because of the cost. So we defined access by asking people whether they could access it or not. And yeah, we have, not everyone likes that, and some people think, well, what if people are lying? And obviously, if you think about it, that would just decrease the apparent effect of the intervention if people who could access medications, said that they couldn't. And the other thing is, now having learned a lot about these patients and our pharmacist has interacted with them multiple times, I think it's pretty clear that these people, we've done documentary films, like we've gone to these people's homes. If you learn about the stories of these people, it's pretty clear that they couldn't afford the medications. And it doesn't actually include, it's important to mention, some people with relatively high incomes, including people with private insurance, who just can't afford the medications because of the cost. And in one of the films, there's someone who has a fairly good income, going over the family books. And I think anyone looking at that would have a lot of sympathy for what's going on.
Nav, thank you very much for the work you do and for this wonderful lecture. I noticed you're a member of the Canadian Task Force on Preventive Healthcare. Does screening for poverty meet the criteria that you outlined for a screening test? And should the US or Canadian task forces look at recommendations for screening for inequity, poverty, or other social determinants of health?
Great. Yeah, I think, obviously both, I think the US Task Force and the Canadian Task Force, they have appropriately have a rigorous lens that they take to all of these screening maneuvers, on the understanding that recommending general population screening or even screening or case finding for a particular subpopulation is going to have enormous resource implications, especially for primary care providers who have other priorities. And I think the current state of affairs is that a screening tool for poverty probably would not exceed the threshold that the Canadian Task Force has for evidence needed to recommend an intervention. It's possible, though, that there would be other interventions. So, it's like some of the other questions that I was, alluding to about specific forms of discrimination or rights violations, where there might be some evidence. I'll just mention, without any agenda, that the Canadian Task Force does accept suggestions for topics, and those are seriously considered. So if anyone in the room wants to suggest this as an area, you'd be free to do so.
Hello, thank you for your talk. I was just wondering if you had engaged with other sectors of society that are really engaged in prevention in your work, like departments of public health or social services organizations, either on specific interventions or on advocacy and policy work.
Yes, thanks. Yeah, all the time, especially through the Health Justice Initiative, where we are advocating for policy change, including including how much people who are on disability get, what are the criteria for getting on disability and remaining on disability. So yeah, we are in constant contact with the government there. Public health, yes. Also, one of the projects that I didn't mention was related to opioid-related deaths. Which, sort of like cost-related non-adherence, actually, interestingly. It's an issue where it's a huge problem in Canada and the United States, and not in other countries, relatively speaking. Like if you look at the opioid-related death rate, it's much higher in Canada and the United States, even when compared with other similar countries like Australia or England that also have problems. So, so we've been engaging with public health there. And I mentioned that just to say that, I think there are, one of the reasons that I really had enjoyed attending this conference a few years ago is because, I learned a lot about the sort of work that was going on in the United States on issues that are equally important in Canada.
Hi, so I'm Marie from Quebec. And I'd like to bring us back to the encounter level or the practice level. And I was wondering about the questions you're suggesting that we ask patients in our regular encounters. And I was wondering if you did any studies on the acceptability of these questions, like have you been discriminated against, or can you afford food or medications? And if people say yes, has there been any type of training to help physicians, once they ask the question, how do they deal with it within the encounter in your work?
Yeah, great. And the answer is yes. So, and most of it's done in the United States. And I should just make it clear, it's not that I had the idea to ask these types of questions. Medical legal partnerships that already exist in the United States have developed these sorts of instruments to help clinicians identify patients who might benefit. They're not exactly the questions on the board, but they are asking about whether or not there's been a dispute with the landlord, those sorts of questions. And I think the answer in terms of how acceptable they are is that they are much more acceptable than the characteristics questions. So, asking someone about their race, I think natural response is, why do they want to know? If you're someone who has been discriminated against based on your race, and then you're going into the doctor's office and they're asking you, to check a box about your race, it's natural to wonder what's going to be done with that information. Is that going to help me? Is that going to harm me? It's harmful in other ways. And I say this with a bias as someone who can never check one of the boxes, because no matter how many categories there are, they virtually never would include the category that would describe my background. So, what effect does that have, before you see a clinician being asked about that? Versus if you're asked, have you been discriminated against based on your race? The studies suggest people are more likely to have a reaction like, okay, they get it. Like, they are asking about this because they understand that people can be discriminated against. But the other part of it is that clinicians do have anxiety about what's going to happen. One, they have anxiety about the discrimination questions because the fear is that patients will then be more likely to report they're being discriminated against in the healthcare setting. or maybe even by the physician. And then also there's a concern about what to do about it. And that's where actually creating the interventions that can help, like having an on-site lawyer, comes in.
Okay, thanks.
Thank you for sharing your insights. I just wanted to ask a question about the 11% increase in adherence findings that you presented. Of course, relative to the other studies, this is substantial. But do you have any insights on what providers can do once they actually are aware of this gap of, having access to medicines but not actually taking them? You kind of allude to this. There's kind of like tension and maybe shame on the patient's part when they're going to see their providers, who in the back of their minds probably are aware that patients aren't adhering. Have you looked into that? Are there any qualitative explorations that you've done to maybe guide clinicians on helping patients in the encounter?
Great. So the first point is just being aware of it. I was supervising a medical student once, and there was a patient who came in with elevated high blood pressure, and I asked, why do you think the blood pressure is still high even though we prescribed these treatments? And the student, having just gone through the lecture, said, I think it's a pheo. It's a type of tumor that causes the blood pressure to be high despite treatments, and the way to diagnose it is to have the patient collect their urine in a paint can, for several days, and then that's sent to the lab, who's very unhappy about receiving it. So I said, okay, we'll do the paint can thing after I ask just one question. So I went in, and basically the literature to answer your question is to ask in a non-judgmental way. So first, you just say, a lot of people don't take their medications, which is true. It's in fact probably true to say the majority of people don't take their medications as prescribed. And then to say, without saying getting into the reasons, just say, in the last week, how many times did you forget to take it? And then often people will say, I never took it. Whereas if you say, everything going okay with the medications, you're taking it every day, you're giving the answer already. And the patient's likely to say, yeah, I'm taking it.
Sorry, just a quick follow-up. So how do we move from there? So do you think the provider can play a role in helping them take their medicines more, or is it beyond the scope?
I think there is a structural issue, right? Medications are relatively expensive compared with people's income, especially if they're low income. So that's a structural issue that a clinician cannot address in one encounter without sort of advocating for systemic change. But there are multiple things that clinicians can do. One is considering the cost when prescribing medications. Two, considering the effectiveness of medications. There were a lot of people in our study where after the pharmacist reviewed the prescriptions, we just stopped a number of medications. So there are things that can be done at an individual level, but there's also a need for systemic change. In our study, there are people with type 1 diabetes who are prescribed insulin, which is really the only effective treatment. So there's not a whole lot that the doctors can do there, other than shifting towards the lower cost insulin products.
Thank you.